Miliaria. Definition. Miliaria, or heat rash, represents an inflammatory reaction around a sweat duct. The reaction is caused by blockage of the duct along with extravasation of its contents into the surrounding tissue. Clinically, miliaria most often appears as multiple small papules. The diagnosis of miliaria falls into three types, depending on the level of sweat duct occlusion in the skin layer: 1. Crystallina, stratum corneum; 2. Rubra, mid-epidermis; and 3. Profunda dermal-epidermal junction. Miliaria, multiple red papules in an infant. Incidence. Miliaria is most commonly seen in neonates, Miliaria crystallina, and in adults who live in warm, humid environments, particularly in skin that has been occluded, Miliaria rubra. In infants, heat rash is recognized by the parents and seldom causes them to seek a dermatologic consultation. However, it is frequently seen on the backs of hospitalized patients who are in a constant, lying position. History. In the ambulatory patient, miliaria is most commonly seen in neonates whose sweat ducts are not completely developed. Miliaria results from exposure to a hot, humid environment. In the bedridden patient, fever, sweating, and occlusion of the skin are predisposing factors. Strenuous physical activity can lead to miliaria. Pruritus is often the presenting complaint. Physical examination. Miliaria rubra, the most common form of miliaria, appears as multiple discrete, small, red papules. It is most often localized to the trunk, particularly the back. Although sweat ducts are not visible, miliaria is suspected when a patient has multiple small, discrete, uniform-sized papules not associated with hair follicles. Less common variants are Miliaria crystallina, with superficial non-inflamed vesicles containing crystal-clear fluid, dewdrops. Commonly seen in infants with clear, fragile vesicles on the face and trunk, and Miliaria pustulosa, with erythematous pustules. Miliaria crystallina, superficial, non-inflamed vesicles, dewdrops. Differential diagnosis. Miliaria rubra and pustulosa may be confused with folliculitis. In miliaria, the pustules are usually smaller and more numerous and do not have centrally placed hair. Sometimes, however, the two conditions coexist because they may share the same predisposing factor of occlusion. In infants, erythema toxicum neonatorum affects half of healthy newborns and is distinguished from miliaria by the red, broad flare around the papules on the face, trunk, and proximal extremities. The eruption resolves on its own within 10 days. Candidiasis also occurs in moist occluded skin, but the eruption is usually beefy red, confluent, scaling, and surrounded by satellite papules and pustules. The word milia sounds similar to miliaria, but the condition it denotes is different. Milia are small, non-inflamed, superficial, epidermal keratin cysts often found on the face of young infants and adults. Acne is distinguished from miliaria by the presence of comedones, characteristic age, and distribution of presentation. Differential diagnosis of miliaria. Erythema toxicum neonatorum in infants. Folliculitis. Acne. Miliaria is a heat rash, milia are small, keratin-filled cysts. Laboratory and biopsy. The diagnosis is usually made clinically. For pustules, gram staining and culture rule out bacterial folliculitis. A potassium hydroxide preparation enables the identification of candida. If a biopsy is performed, serial sections must be done to reveal the intraepidermal portion of the sweat duct, which is surrounded by spongiosis and a chronic inflammatory cell infiltrate in the epidermis and superficial dermis. Miliaria. Epidermis. Occluded sweat duct with underlying intraepidermal edema and inflammation. Dermis, superficial inflammatory cell infiltrate. Therapy. Therapy is directed at removing the predisposing conditions. Most important are cooling measures and air exposure for occluded skin. For ambulatory patients, this is easily accomplished. For bedridden patients, this means ensuring that the bed is dry and the patient turns frequently. In infants, miliaria resolves on its own without intervention. A mild to mid-potency topical steroid cream or lotion can be applied to help relieve the itching, but this must be done sparingly to avoid any further contribution to the occlusive process. Therapy for miliaria. Initial. Cooling measures. Air exposure. Topical steroid, hydrocortisone 2.5% or triamcinolone 0.1% cream. Course and complications. With decreasing heat and increasing air exposure, the condition resolves spontaneously within days. Complications are uncommon. Conditions that predispose to miliaria, however, can also contribute to coexisting infections with bacterial and candidal organisms. Pathogenesis. Occlusion of the sweat duct is the primary event in the pathogenesis of miliaria. In Miliaria rubra, this occurs within the epidermis at the level of the granular cell layer. Increased hydration appears to play the major role, resulting in swelling of the stratum corneum and compromise of the ductal lumina. After occlusion, sweat extravasates into the epidermis, where it produces an irritant reaction. In Miliaria crystallina, sweat duct obstruction occurs in the stratum corneum. Experimentally, stripping of the stratum corneum with adhesive tape restores sweat flow, providing evidence that the occlusive process occurs in the stratum corneum. Bacteria and increased sweat tonicity have also been implicated pathogenetically in miliaria, but their pathogenetic roles have not been proved conclusively. Miliaria rubra. Miliaria crystallina. Miliaria pustulosa.
Clinical case. A 24-year-old man presents during the summer with a 5-day history of an itchy skin eruption. He reports excessive sweating due to working outdoors. On examination, there are numerous small, erythematous papules and vesicles on the upper chest, back, and neck. Some lesions appear superficial and clear, while others are red and inflamed. There are no comedones or pustules. The patient denies systemic symptoms. What is the most likely diagnosis? A. Miliaria rubra. B. Erythema toxicum neonatorum. C. Folliculitis. D. Acne vulgaris. E. Miliaria crystallina. Answer: A. Miliaria rubra. Explanation: Miliaria rubra, heat rash, is caused by obstruction of sweat ducts in hot, humid conditions, leading to pruritic erythematous papules and vesicles, commonly on the trunk and neck in adults. Option E, Miliaria crystallina, is a close differential but presents with clear, superficial, non-inflammatory vesicles without erythema or itching, which doesn't fully match this case. Erythema toxicum neonatorum occurs in newborns, not adults. Folliculitis presents with follicular pustules, often with central hair. Acne vulgaris typically includes comedones, blackheads, whiteheads, which are absent here. Thank you for your attention.